As many as 84% of women transitioning into menopause and beyond will experience problems with their sexual health, from low libido to vaginal dryness and pain. And today we're going to dive into this and how to treat it and more on the Wild Wisdom Show. Hi, I'm Dr. Patricia Mills, holistic medical doctor with the root cause approach to health. And today we are talking about effective solutions for menopause-related sexual changes, from low libido to vaginal pain and dryness. Now, what's important to understand is that these changes can happen as a result of issues related to the psychological impact of transitioning through menopause, but also they are as a result of the low estrogen and testosterone that can occur during the menopause transition as our estrogen drops and as testosterone can also drop, as both are produced by the ovaries. And it's that decrease in ovarian function that transitions us from perimenopause into menopause. And what's interesting is that this depletion of estrogen and testosterone affects locally, as in areas like the vagina and the clitoris, and it also affects the brain. So our brain actually suffers for a period of time as we're transitioning. And the hope is that over time, the brain adjusts to this transition. But during that adjustment, we can have the experience of low sexual desire and changes in our sexual health. So we need to address both the local effects of the menopause transition as well as the brain effects to experience optimal sexual health at any age and with any hormone status, because that is our right. Now, let's dive into the local effects of estrogen deficiency in tissues like the labia, the vagina, and the clitoris. And what happens is, because as the ovaries start to run out of eggs and produce less of that estrogen over time, we can experience thinning of the skin in those areas, loss of elasticity, and dryness. So loss of the lubrication that is released that causes that area to remain moist and then to be lubricated during intimacy. In fact, there's a name for this in medical terms called vulvovaginal atrophy, VVA, and dryness, and this can affect 20 to 84% of menopausal women. In addition to these local changes in the skin tissue and the lubrication and moisture, we can also have changes in the vaginal microbiome, and the entrance between the vagina and where we pee can be shortened, like it's a decreased distance. And as a result, we can get an increased risk of infections, not just in the vagina, but also with urinary tract infections. So common signs of problems with vulvovaginal atrophy and dryness is the dryness. It can be experienced as irritation, burning, soreness, tightness, frequent or recurrent urinary tract infections, lack of moisture with sexual activity, and then pain with intercourse. And for many women, this can be quite problematic and start to interfere with our self-confidence and with our relationships. And the good news is that there are treatments for it. However, if we ignore it, it tends to be a chronic condition that will get worse without some kind of therapy, because that estrogen depletion remains over time. So if you're experiencing these issues, we do want to cover what are some of the strategies you can use to improve it so that you can experience better health down there. Before you go into treatments for the vulvovaginal atrophy and dryness, you do need to rule out a vaginal infection first with your doctor. So it could be a bacterial or a fungal infection that could cause these symptoms as well. And those would require, an antibiotic or antifungal and would clear up with that treatment. But the estrogen deficiency related dryness and thinning of those tissues down there would not improve with antibiotics or fungal treatment. So that's also another way to differentiate. But the doctor can take a sample of the tissues down there and of the liquids down there and test for any bacterial and yeast infection, just to make sure that that's not what's causing your current symptoms. So let's cover some available treatments for the thinning of the tissues and the dryness. So the treatments range from moisturizers to lubricants that you might use during intercourse, vaginal probiotics. That's a really interesting field where a lot of companies are looking into what is a typical healthy microbiome in the vagina. So the microbiome is a collection of bacteria and yeast and fungi that are meant to be in your vagina. They do help maintain a healthy community of organisms there, and their job is to maintain that lubrication and the skin integrity. So they assist with that. And so the thought is that if we can introduce some healthy probiotics into the vagina, we might support that community, which in turn would support the health of our vaginal tissues. The other treatment is actually pelvic floor physical therapy, because sometimes the pain with intercourse comes from weaknesses in the muscles that we can experience as we age. So it may not even be due to estrogen deficiency. It could actually be due to loss of muscle mass with aging if we are not doing things to maintain the strength of our pelvic floor. And doing some pelvic floor physiotherapy is very useful for addressing this problem. Also, sometimes the estrogen deficiency can lead to things like uterine prolapsing. So the uterine tissue becomes so thin that it starts to not be supported well in the abdomen, and it can drop down into the vagina, and that can start to cause problems with intercourse. And some of that may improve with pelvic floor physiotherapy. And if not, some women even go on to have surgery to lift the uterus up, and some will even go on to have a hysterectomy where the uterus is removed. But starting with the basics, essentially doing that pelvic floor physiotherapy. And then the other potential treatment is a local use of hormone therapy like local estrogen, or what's called DHEA. DHEA is the hormone from which estrogen and testosterone are made. And the really cool thing is that the use of local estrogen and local DHEA put into the vagina, whether it's through a cream or suppository application, it helps the local tissues without increasing our risk of breast cancer. And DHA also does not increase our risk of cancer of the uterus. Now, estrogen on its own could, which is why often the use of estrogen needs to be combined with progesterone, because progesterone is protective of uterus cancer, or what's called endometrial cancer. But the cool thing about using these local therapies is that they can prevent the occurrence of long-term consequences like that uterine prolapse by maintaining the healthy levels of estrogen in those tissues very locally without affecting the rest of the body. So these topical local applications of hormone therapy can be extremely beneficial and have been proven to help with these conditions very well. Now, this is not for everybody, and I do want to make sure that even if you're on hormone replacement therapy, that you are addressing all the other kind of support that you can for your vaginal health. So let's cover some of the moisturizers you can use. Now, I did look at the options in terms of moisturizers and lubricants, and what I can say is 99% of options for vaginal moisturizers and lubricants contain additives that could actually harm the health of your vaginal microbiome, like sodium benzoate or potassium sorbate. Like all of these chemicals that have been proven to harm microbiomes are being put into products that have lovely labels like natural and organic, and you would think they would be great for you, but if you read the description, like the ingredients, they have chemicals that I personally would not be wanting to put in my vagina. So one option that you can use is 100% aloe vera. That is very nourishing to the tissues and won't cause any issues with the local microbiome. Vitamin E oils and other oils like olive oils and coconut oils, those have been used. They're not as well studied. We are not exactly sure what the effects are on the local microbiome, but I think they would be infinitely better than using these preservative chemicals, which are designed to, keep that product that's going to be on the shelf for a prolonged period of time without going bad and getting infected. But the downside is that when you put it in your vagina, you could actually harm your own vaginal microbiome. So just want to be sure that you're aware of this. And as a lubricant for intimacy and sexual intercourse, you can use 100% aloe vera. The good news is that it doesn't interfere with the integrity of things like condoms. And you might be wondering, why would I have to worry about a condom when I'm in menopause. Well, in the early years of menopause, so in the 2 years after your last menstrual period, you may still actually have enough eggs in your ovary to get pregnant. So some women actually can get pregnant within the 2 years after menopause, which is your last menstrual period. So practicing safe sex during those 2 years is important still. So good to know information, right? Now, local estrogen or the use of local DHEA, as we discussed, what we want to focus on is that it's a very low dose therapy. It doesn't seem to increase any kind of levels of estrogen or DHEA in the blood when you apply it to the vagina. And it's been tested. And so far, there is no risk of breast cancer. And again, if you have a uterus still, you want to combine the estrogen with progesterone, but the DHEA you can use on its own. And both have been shown to be very effective with improving local pain and dryness and the health of the tissues, which theoretically would prevent you against urinary tract infections, that increased risk, the increased risk of uterine prolapse. So that's the benefit of that local therapy. But what it won't address is if you have issues with sexual desire and low libido. That requires a different treatment that we're going to get into. And if you're watching this live, please feel free to put your questions in the comments. I'd be happy to answer them for you. So the low libido, it can come from, having pain or dryness with intercourse, in which case that local therapy will help with that. But a lot of the low libido and menstrual in our menopause transition comes from the effects of lower estrogen and testosterone levels on the brain. So the brain actually has what are called receptors, as in they receive the hormones, estrogen, progesterone, as well as testosterone. And those hormones, when they interact with the brain, will trigger certain activities in the brain. And for example, testosterone is really important for things like mood and sexual health and libido, amongst other things. And so what happens is that we can actually get low libido from that declining levels of the estrogen to testosterone and progesterone, but primarily the testosterone seems to be at the biggest play when it comes to this. Now, interestingly, testosterone production still happens in the ovaries after menopause, although to a lesser degree. And it looks like we get more of an estrogen loss than we do testosterone. So some women can actually have increased sexual desire after menopause, in that their testosterone levels are relatively higher than their estrogen compared to how they were before menopause. But some women have such a decline in their ovarian function, and this can be genetic, but it can also be due to lifestyle factors like inflammation affecting the ovaries, problems with nutrition, sleep, stress, lack of appropriate exercise. All of these things can increase inflammation and lower ovarian function. So we might be seeing actually quite a few more women having problems with libido rather than having an increase in libido in menopause. And there is a medical term for this, and it's called hypoactive sexual desire disorder, or HSDD. And when this is diagnosed, the clinician or the doctor has to differentiate it, and you as well as the person experiencing it. Is this actually as a result of hormonal shifts? But could this be from stress, right? Like a busy schedule, lots on your plate, many obligations that can decrease libido independent of hormonal changes. Can be due to relationship conflicts, interpersonal or psychological issues, cultural influences. Like in some cultures, it is expected that the woman loses desire and engages in less sexual activity as she ages. However, from a physical perspective, this couldn't be further from the truth. It is absolutely possible and healthy to maintain good libido no matter what the age and hormone status that we have. So the cultural influences can be strong. Also, other medical conditions such as hypothyroidism can also affect libido. So having your thyroid levels tested to rule out any issues with thyroid health is also important. But if you have ruled all of these things out, And what you have is true low libido or hypoactive sexual desire disorder from the menopause transition, from that lack of testosterone, for example, getting to the brain. Then one of the primary therapies that has been shown to be extremely effective is testosterone creams or gels applied to the skin, used in mini doses compared to what men use. So interestingly, although testosterone is thought to be the hormone of men and estrogen primarily the hormone of women, we actually as women have more testosterone than estrogen and progesterone in our bodies. If you look at the absolute amounts, which is kind of crazy, but we do have less testosterone than men and less testosterone receptors than men, and we have it in different parts of the brain and in the body. So that's the major difference. But we can actually use the testosterone therapy to correct things like hypoactive sexual desire disorder or low libido from the menopause transition if our testosterone drops too low to the point where it's affecting us in this way. Now, this can really be well supported if we're having the psychological interpersonal issues with things like counseling and cognitive behavioral therapy, which essentially is therapy that allows us to change the way that we perceive our relationship with sexual health and sexual activities. And what we do know is that we need to break this paradigm of, thinking that as we age, it's normal to not feel sexual anymore, to have less sexual interests. Maintaining sexual activity and communication about our desires and needs can contribute to fulfilling and satisfying sexual experience, regardless of age or hormonal changes. So we need to look at all of the strategies, all of the tools in our toolbox to be able to do this. So here are some strategies that I want to offer you that you might find helpful. So one strategy, actually simple, and this kind of has to do with cognitive behavioral therapy, is to think about sex. Think about it, daydream about it, maybe read about it. Maybe there's some movies that stimulate your sexual desire. Just keep that flame alive. Keep it in your mind and hold it up and inspect it every now and then. It will fuel that sexual desire. The other strategy is to shop for fun toys. Did you know that there was a time that the treatment for the menopause condition was providing women with orgasms? And initially, doctors would use manual therapy to give orgasms, in that they were using their hands to stimulate orgasms in women by rubbing the clitoris. And then one intrepid doctor invented what is now like the sex toy, the vibrator. And so getting a really great vibrator, for example, that you really love, that really works for you, stimulating the clitoris and getting those orgasms and getting those juices flowing will keep those networks open and keep that physiology active so that you're more likely to maintain it over time. The other strategy is to get creative. So maybe vaginal intercourse isn't feeling really great for you yet. Get creative and think of massages, sensual baths, caressing, oral sexual stimulation. Speaking to your partner, which is the next strategy, is speak up, communicating with your partner saying, these are physical changes that I'm going through. It has nothing to do with how I feel for you. I still desire you and I still have sexual needs. And we need to get creative and find ways that we can arouse and stimulate so that we can engage in an intimate relationship with each other. And for the meantime, while I'm figuring out this vaginal health issue, can we use non-vaginal ways to be intimate with each other? So speaking up and communicating your needs and what's going on can be so empowering during this phase. And lastly, don't stop. Don't give up. If having a healthy sexual life with yourself or with your partners or with your one partner, if that's part of what gives you joy, you don't have to give that up. Connect with an experienced prescriber and provider if you need that hormone replacement therapy. If you're listening to this or watching this and you're wondering who can be the one to prescribe you, in the US, you can check out the North American Menopause Society and look at who's a prescriber, because these are certified providers that can have been trained in the use of things like testosterone therapy for low libido. In Canada, there's an online platform called Science and Humans, where it's staffed by certified and trained nurse practitioners, which is wonderful because they're very experienced, but it brings the cost low. And I've had friends and patients use their services with great success, and you can access it from almost any place in Canada online, and they ship the prescriptions to your door. It's a wonderful service. So I just wanted to bring that up because often the question that I get is, well, how can I find someone who will prescribe this for me because my family doctor or my gynecologist doesn't do this, or they don't want to, or they're recommending that I don't use this. The truth is that at least in Western medicine, as far as I'm aware, I don't know about other countries, but family doctors and gynecologists are not trained in the use of hormone therapy for the menopause transition, using doses for that rather than using, for example, oral contraceptive options, which are much higher doses and are not meant to be used for the menopause transition. They're meant to be used for contraception. So the doses and the types of hormone therapies used for menopause transition should be completely different from what a doctor would offer for contraceptive use. And so we are not trained in this in our regular training. These doctors would have to have done additional training with organizations such as the North American Menopause Society in order to be able to actually prescribe you and have this conversation with you about the hormone therapy. But remember, you can't out medicate or out supplement a lifestyle that actually isn't supporting the health of your brain and your vagina and your ovaries, for example. So you still need to focus on your nutrition, your exercise, your sleep, and your stress reduction. For example, cardiovascular exercise will bring blood flow to the brain, blood flow to the ovaries, blood flow to the vagina to maintain that healthy tissue. Strength training also improves hormone health at the level of the brain and more. The right kind of nutrition will give you the building blocks to keep your brain healthy through the menopause transition, which is so crucial. And stress reduction really preserves the existing progesterone, testosterone, and estrogen that our body is still able to make. If we have high levels of stress, it'll pull away from those hormones to make the cortisol hormone, the stress hormone. So we need to be able to combine all of these strategies for a holistic approach for sexual health. So I'm so happy that people have been joining me today. Thank you for saying hi. And I look forward to seeing you on next week's Wild Wisdom Show, and wishing you a wonderful rest of your day, evening, or night, depending on when you catch this. And if you like this, if you found it useful, please share this with someone that you think may benefit. Have a wonderful rest of your day, and I'll see you next time.